Good evening, Endo Summit Live, and welcome to our third edition in this season. We have a very exciting evening for you because we are talking all about adhesions and endometriosis. For those of you joining us on Instagram Live for the first time, we are happy to have you. Facebook, YouTube, and LinkedIn, we are thrilled to have you as well. Please welcome our season's co-host, Dr. John DeLumba. Dr. DeLumba, can you introduce yourself?
Sure. Excuse me. I'm John DeLemba from Texas, down in Denton, Texas, a little bit north of Dallas. And on December 31st, I'm going to stop doing surgery because I'm getting old, but I'm going to still be doing some other things. Some people invited me, and I'm not going to be doing surgery, but I'm going to still be seeing some patients as consultant and things like that. So I've been doing this for a long time. I do have a huge focus on adhesions. Because in my opinion, endometriosis is horrible, but it's a disease. Adhesions, sadly, are normal because it's the normal healing process of our body. And I don't know if we have time because I will probably have to leave about 7:40, about 45 minutes. But I'd like to share with people on one of my classmates' discovery that he won the Nobel Prize for in medicine in 2019 that will have a huge impact on the healing process. It's actually not healing, it's regeneration. So
very cool. Also joining us this evening are the California crew, and they are significantly earlier than we are. So we are very grateful to have them. Dr. Fathatcher, can you introduce yourself? You are a first-time Endo Summit Live participant. You're muted.
Thank you very much for inviting me. I'm Surena Fathatcher. I've been trained for endometriosis and minimally invasive surgery at Center of Endometriosis Care. And then also I've done Urogyn Fellowship. So I've been doing endometriosis pretty hardcore for the past couple of years in Long Beach, California. And thank you very much for inviting me to participate.
We are excited to have you. And now our other Northern Californian, Dr. Mona Orati, who is coming to us from her brand new practice. Can you introduce yourself?
Yeah, so my name is Dr. Mona Orati. I'm a minimally invasive GYN surgeon. I've been practicing for over 20 years, doing minimally invasive surgery, and probably the last 10 years I've been exclusively focused on endometriosis and fibroids, or actually more than that probably. And we did just open the Orati Women's Clinic here in San Francisco, which is meant to be a center for holistic care for women with menstrual disorders, fibroids, endometriosis, and obviously excellent surgical care as well, in order to help women get out of pain, get pregnant, have a happy sex life, and all the things that we need to help our endometriosis patients and women in general to achieve.
Yes, there is one Endo Summit Live, which I'll broadcast actually from San Francisco, because I'm going out to do something with Dr. Wasson, and I thought I should stop by. If the time works,
I'm going to have to visit.
Yeah, I think that'll be cool. And I'll get to see the kids. So let's get right to it. Let's talk about adhesions. What is an adhesion and what kind of symptoms might they cause, Dr. Orati?
So adhesions is basically abnormal tissue or inflammatory tissue that develops, that adheres or sticks some structure to another structure. So basically anytime two organs or two different structures stick together, those are called adhesions. And they can be filmy or thin, they can be thick, they can be dense, they can be solid, they can have blood vessels, they can have nerves, they can be innervated. It depends on what causes adhesions and how it developed and how long it's been there. Things that adhesions can cause is a lot of things. So in women specifically, adhesions around the fallopian tubes can cause fallopian tube dysfunction, can cause swelling of the fallopian tube, and therefore cause infertility because of the inability of the fallopian tube to transfer the egg to the uterus. Adhesions around the uterus or around the rectum or around the bladder can shift organs. So the ovaries can shift, things can get stuck together, the ovaries can get stuck, the uterus can be stuck to the sidewall, the bladder can get stuck to the uterus, the rectum can get stuck to the uterus. So things can kind of adhere together. And very classically in what we call, stage 4 endometriosis or the frozen pelvis, is kind of where everything is stuck together from that severe inflammation caused by the endometriosis, that just everything is kind of brought to the midline and everything's stuck together. The ureters are displaced, the bladder is displaced, the rectum's displaced, the bowel is displaced, and everything is adherent together. And that causes a lot of pain. It can obviously infertility. It can cause bowel symptoms, bloating, partial bowel obstructions, indigestion, painful bowel movements, severe constipation. It can cause bladder symptoms, feeling like you have to pee all the time, urgency, frequency, and then it can just cause pain on the right side, pain on the left side, pulling pain, sharp pain, all sorts of different kinds of pain. So adhesions is a component of endometriosis. Now, not everyone with endometriosis has adhesions, but everyone with severe endometriosis, where there is a severe inflammatory component, adhesions can develop and distort and displace organs. And a lot of times that's why things are shifted around. And a lot of times it does contribute to pain and infertility. And as an endometriosis surgeon who goes in to remove endometriosis, especially in younger women or women who haven't had kids yet, it's very important for us to focus on preventing those adhesions from reforming or preventing the trauma of doing surgery itself from causing adhesions that can cause problems in the future.
Very interesting. I wonder, you said a sentence I think we could have a little discussion about. I mean, millions of sentences.
Millions, yeah, right.
This is one sentence. So, Dr. Jalumba, Dr. Fathatcher, Dr. Arati said adhesions are an abnormal tissue. Do you guys have a theory or a comment on that? Go ahead, Dr. D.
Well, I don't think it's abnormal. It's actually normal. When our genetics are such that when we are injured in any way, that we have to heal. And one of the things that Dr. Jung presented we discussed it at their last Endo Summit meeting in Florida last year, was that if you operate on a fetus before 24 weeks, they are born without a scar. Mm-hmm. But if you operate on a fetus after 24 weeks, they're born with a scar. And nobody's figured it out until my classmate's discovery, and he didn't even think about it. I sent him an email. He goes, oh my gosh, we never thought of that, but they did some studies. So why would somebody at 24 weeks or before not scar? Because that tissue is hypoxic. And our HIF1, hypoxia-inducing factor 1, is turned on when it's hypoxic. Once we become oxygenated, when that skin is now thicker and it can get blood flow, it turns off. Think of a salamander when we pull the tail off. It doesn't scar. It comes back as a normal tail because many amphibians have HIF1 on. That's what I was talking about earlier. So for humans, when we are injured, I just fell last week when I was taking my grandson. We were doing paintball. I was thinking I was a lot younger and faster, and I fell and cut my knee. It's almost healed from Sunday to Monday, 8 days. It's basically healed. But there's going to be a tiny scar there. It doesn't come back as normal skin. So there's abnormal aspects, as Dr. already mentioned, but you can have fibrosis. You can have scarring. I mean, think of a burn victim. They'd love to have normal skin growing back, but they don't because it's been damaged so severely. So it's a normal process causing abnormal things, in my opinion. And it starts from red blood cells, platelets, blood clots, fibrin, fibrinogen, inflammation, a whole cascade of events. And one thing I did want to mention, because Dr. already went through a whole litany of what can cause it, but sometimes we forget even ovulation has the potential to cause adhesions. Because when an egg pops out, what can come with it? Blood. Now we've got a raw surface and you have blood, and organs can start to stick to each other. So it's just so fascinating. They don't teach us a lot of this in medical school and residency. General surgeons are taught adhesions don't cause pain unless there's complete or partial bowel obstruction. It's crazy.
I agree with John. I think actually I have done a study for 3 years for when I was a Urogyn fellow in University of Oklahoma regarding a prolapse is actually the chronic inflammation of the muscle injury that it doesn't regenerate and it does not complete the cycle. So what happened is the fibrotic tissue is actually causing prolapse for women in pelvic. And basically the birth injury that the pelvic floor gets and then end up resulting having advanced prolapse in the future on the genetically predisposed people and patient. So I do think I agree with John. I think that what happened here is I think the process doesn't get completed and the adhesion happen. Adhesion is actually can be kind of like the defense mechanism of the body. Basically, when you cannot complete the process of the healing, and then you create the surface of a tissue in between another tissue is just basically providing some sort of a barrier to get more damage because the fibrotic tissue protecting another tissue. However, that I agree with John. I think that adhesion can cause many things. Can cause the effective of motility of the bowel. So it basically can affect the bowel angle and then can causing the GI symptoms for the patient, obviously, and can cause pain by pulling on the muscles and the nerves. So I agree. I think that the whole thing is just not completing the injury process in the proper way, ending up with more adhesion. And as we have seen stage 4 endometriosis in very young patients. When I think I've seen a stage 4 endometriosis in 24-year-olds up to 22 years old. John is more experienced, probably seeing more, or all the way if somebody is low stage of endometriosis, being delayed diagnosis and had multiple other surgeries with other surgeons, and then all of a sudden showing up at the age of 37 with a stage 4 endometriosis. Because the whole damage, the whole injury, the repetitive injury that does not complete the cycle, causing this kind of fibrotic tissue and then causing a damage to the tissue, causing the dense adhesions.
Yes, one thing I always think about with adhesions, like I started in orthopedics. So when you have an ankle sprain, that's ligament, right? You're never going to regrow ligament. When you are rehabbing an ankle, you're regrowing basically scar tissue, right? And the goal is to have the scar tissue, instead of organizing like this, to do in an orthopedic sense, the physical therapy or the bracing or whatever you're going to do, to have it laid down in an organized pattern. So I think adhesions happen as a response to insult to the body. It's just on a whole other level when it's surgery versus like an ankle sprain. Now, one thing that's unique with endometriosis is the disease itself creates adhesions. Does anyone want to comment on sort of the difference between adhesions created by the disease and adhesions created by treating the disease?
Yeah, I mean, that's what I was talking about. So partly what I was mentioning. So adhesions created by the disease is because endometriosis is endometrium by definition that's growing outside of the uterus in areas where there's no normal.
We have the shirts. We have the shirts even. That endometriosis is not endometrium.
Endometrial tissue.
It's not endometrium. All right, we can't have that debate here. We can have that at the summit, but
so endometriosis,
logically, it's not endometrium.
Okay.
I missed the big guy though.
Okay, fine. Endometrial-like tissue, but
sorry to interrupt. That's actually my argument with pathologists, because I go to exercise all this endometriosis and they don't read it endometriosis sometimes because they don't know. But thank you. Go.
Thank you. So the inflammation caused by that abnormal tissue that's growing on the other surfaces of the pelvis causes an inflammatory reaction, cytokines, and all sorts of inflammation. And that inflammation is what causes the formation of the adhesions and things to shift and things to stick together. So that's a different type of inflammation than the adhesions that form from surgery. Adhesions form during treating the disease or cutting out the tissue is that if we can minimize the trauma, we'll minimize the adhesions. But every time you touch something or you traumatize something, an inflammatory reaction then happens because of the healing. And that inflammation, again, those cytokines, collagen, things lay down, and that causes the adhesions to form as the healing process develops. So adhesions form because of inflammation, because of trauma. It's the healing. That's how the body heals, is to form those adhesions. So it just in endometriosis, if we can minimize the amount of inflammation in endometriosis patients, it's possible we could minimize the adhesions that form over time. And similarly in surgery, if we can minimize the trauma that we are causing tissue while we're doing surgery and help the healing process to happen with less inflammation, less cytokines, less macrophages, less inflammatory reaction, we can minimize the adhesions that form after surgery as well.
I'm going to make it very simple. So I think it's if somebody is not in medicine, understand it in a better way. When we have inflammation, what's happening to the organ? When there's inflammation, means there's edema and there is heat. And what is heat does to the body, and the proteins get denuded, and then causing basically when you have a meat, you're grilling a meat in an oven or something like that, you will see the protein get charcoal, right? But not to that level. When they get their two organs in the body, they have inflammation and they have higher level of a temperature from the normal body, they can adhere together to the surface. And that the higher of the temperature, the more dense adhesions. That can happen to the organs, including like the liver to the diaphragm. It can happen to the bowel, and etc. Or maybe you gotta have endometriosis somewhere else. I think that's an easy way to explain it. However, the difference between that adhesion versus the iatrogenic adhesion, which means it's been produced by surgeons or previous surgery. I think after surgery, bleeding is causing adhesions. So if you use the more delicate dissection you have, the less bleeding you have, and the more that you actually using like a new product like PRP and etc. to prevent to actually help him with the coagulation factor and cascade, then you're going to have less adhesion in the future. So I think those are the two different things. That's why I think as an endometriosis surgeon, I would like to have a patient that basically a virgin abdomen or virgin pelvis. I think that's the best
one. We'd all love to have virgin pelvis.
We all love that.
and exactly. But here's the key though, when you go back in on your patients, you will still want to have like a virgin pelvis. Like that's my goal, that when I go back in on a patient that I operated on before, that there's no adhesions, that it looks just like I did the first time.
Oh, so, I'm a big fan of 80s, so I always play 80s in my operating room. So yes, like a virgin is a good one.
Like a virgin, right?
But, yeah. But I do think these are the two differences between we surgeons creating adhesions versus the natural adhesions. That natural inflammation versus
I think we have to
bleeding
we have to try to minimize both, right? And
correct.
I'm sure there's going to be more studies, because I mean, patients with endometriosis, it's progressive. Even, sometimes it comes back. Sometimes adhesions form even after you've removed it. Or, you have endometriosis and you don't want to have surgery now. You're a teenager and, you're treating it. Is there a way that we can prevent them from then becoming that frozen pelvis later on? Is there some way we can prevent the things from sticking together and the severe inflammation that happens with endometriosis, so that that it doesn't progress as fast and cause as much adhesions? I mean, there's really two components. We want to prevent adhesions before, and we want to prevent adhesions afterwards. So,
although also beside that, I think the genetic factor also has some sort of a role here. If and then also high risk behavior. If you're, for example, if you have endometriosis and then you had PID, means STD, that can cause problems on top of another problem for the surgery. So I think those are the two things that you have to think about, which one is endometriosis, which caused by endometriosis, and which one caused by other things.
Well, I mean, not just PID, which is an infection in the pelvis, but have you ever thought of those patients that go to the ER and they're told, oh, you have a ruptured cyst and there's blood in their abdomen, like you can literally see the blood, and they tell them, oh yeah, just go home. It'll go away. I'm like, I want to laparoscope those people and clean out all that blood. Like all that blood that's coming out of that ruptured cyst or endometriosis tissue or whatever it is that just ruptured and spread all over the place. That's going to cause adhesions. Like, especially these younger women, why can't we stick for me, I'm a mini person. I would stick a mini laparoscope in them and just wash it out and just like help them. First of all, that blood is what's hurting them, right? It's causing inflammation in the peritoneum. Why can't we clean out that blood and stop sending home all these people that go to the hospital with ruptured cysts? Because I think we're just buying them adhesions.
I don't think any of them really have rupture. I don't think that many have rupture cysts as the ER tells them to have that, but that's a whole other live.
Some do though. I've seen patients where I see them post their ER visit and they still have blood in their pelvis,
Yeah. Let Dr. DeLumba, you want to comment? And then we happen to have a webinar crasher that was watching. Okay. Dr. DeLumba, you first.
Okay, Dr. Hardy, you're absolutely correct. And this actually was looked at back when laparoscopy was still in its infancy, with infection, with bleeding, anything, that instead of just watching them put them on antibiotics, which you still can do, you go in and you clean it out, and they're going to see significantly less pain and issues in the future. And Dr. Fadicher, you're absolutely correct in that you have to find ways to decrease these adhesions. And so when I talk to my patients, I talk to them about exactly what you mentioned, accuracy and precision. And that's why, as a robotic surgeon, having been a laparoscopic surgeon, I think the accuracy and precision, getting rid of more endometriosis and accuracy and precision in those tissue planes is key for any surgeon to decrease adhesion formation. The second is many of us are using heated and humidified carbon dioxide, not for where we operate. It's for the non-surgical areas that can dry out on a long surgery. So it's like holding your eye down and doing this. And then at some point, I think we can talk about barriers. But the last one, and I want to get this in here, so it's called a second look surgery. There's only 2 people that I'm aware of, other than maybe some infertility docs, that do second looks as gynecologists. They're used in every other specialty, like general surgeons for bowel stuff. Well, a lot of the data out there has not been supportive of this. I've been doing them for about 20 years because a doctor in Germany, Dr. Krasinski, convinced me. So what you do is you do your surgery. You do everything you're supposed to do, cut out the endometriosis, cut adhesions, do everything you're supposed to do. And then you go back in within 3 to 7 days after surgery. Why? Well, because that's the healing cascade of events. And when we were at the Endo Summit, I put up a slide that showed from October 2009, an article that talked about this. And it says by day 3, you've already formed the adhesion. By day 5, it's starting to get blood vessels. There are no new adhesions from that injury, say surgery, after day 7. So the theory is by interrupting this cascade of events, which isn't smart, that you may see less adhesions. So I know what works as barriers, what doesn't work as barriers, how many patients get adhesions. About 80% of patients get adhesions. 20 don't, but I can never tell who. I thought, oh, this lady's going to have tons. None. Oh, she shouldn't have any. I hardly did any adhesions. So you don't even know, but 20% don't. But by interrupting that cycle, and I don't do it, but it was done in some of the Scandinavian countries, Dr. Jansen did it. They did a third look to see how effective it was when you interrupted in that cycle, in that cascade. 70% of those adhesions that were there on the second look did not form or reform, but 30% did. So it's not perfect, but it is really beneficial in patients, especially when you see adhesion, when you see pain about 3 to 6 months after surgery from an endometriosis focused doctor that's got good skills. 3 to 6 months, and all of a sudden they're hurting again. And they go, my endo's back. I'm like, am I that bad that in 3 to 6 months your endo's back? No, it's almost always adhesions. And when we get that all the time pain, that's from adhesion, scarring, and fibrosis. I had to throw that in. Sorry.
We have Dr. Chung joining us, who was watching and decided he needed to jump out of his seat. Dr. Chung, you have a comment?
Could you hear me?
No, yeah, I can hear you now.
Yeah, we
Okay,
can hear you.
I support what John was saying. All these adhesions form within the first week,
Mhm.
but I think there's a lot to do with genetics, because adhesion form and then the fibrinolysis is supposed to help out with clear the adhesions. So that's a genetic. When it fail, adhesion form. So does adhesion cause pain? Not necessarily. And we have all these, you know, John, you are as old as I am. Well, you're a little bit more senior. But
Okay,
what I'm
Dr. Chung,
saying,
I do have to say one thing. All you have to do is look at a burn victim.
Yeah.
Look up New York City fireman face transplant. And he was going blind, not because his eye was injured, because they would cut the scarring and the fibrosis that was squeezing, and they had to give a new face, because you can cut the adhesions all you want. Now you got two raw surfaces like spaghetti and meatballs in there. Your body doesn't know good from bad healing. It has to fix itself.
that's right, exactly. Adhesion form from whatever inflammatory changes, infection, trauma, it's going to form adhesions. And then when adhesion form, when the body doesn't know how to take it down, that's going to form the permanent adhesions.
But
So-
our role as surgeons is to minimize the trauma so that we can minimize the adhesion formation.
Well, yes,
and to try
exactly.
to help that healing process in order to try to again minimize the adhesions. My point is, as surgeons, I don't think we can blame genetics or surgery or endo for all the adhesions. I think we have to kind of, you know, take some responsibility and say that we have to do everything we can do as a surgeon in order to prevent
Well,
it.
I think
So Dr. Chung, Mona is
I
right.
agree
We're
with
not
you,
we're,
Mona.
we're,
I
we're
agree
not we're not arguing about the root of adhesion. We say, well, this has happened, right? There's two different adhesions. One is basically endometriosis caused adhesion. The other one is a surgeon causing adhesions. But then we're gonna come to see how we're gonna approach this adhesions in surgery, right? Because you're about to operate on the patient and you have a frozen pelvis. How are you gonna approach that? So you should be able to, I think every one of us should be able to process that, okay, I'm about to operate on a stage 4 endometriosis. Okay, so be ready for it. What am I gonna do about that? So think about that. I think that's the main, that's
Yeah.
just gonna be more productive conversation, I think. So
Exactly, yeah.
I agree with you though. So when there's a frozen pelvis, that's already adhesions. So are you gonna not take it down because of adhesions? But when it's
No.
endometriosis,
no, we are
My
taking
point
it
is that
down.
how are you going to take it down, and what are you going to do to prevent it from reforming and sticking?
Well,
back?
that's the next
That's the
next
thing,
part
yeah.
of the discussion.
Well,
Yeah, that's
So-
my
what I was trying to say. Adhesion form because of inflammatory changes. When you remove adhesion, 80% of them is going to reform. That's a given. There's no doubt about it from the same site. Okay? That's studies and study overprove that it's adhesion reform is 80% on the same site. But again, though, if it's adhesion caused by endometriosis, you remove the adhesions. They're very good. But I think the technical skill of minimizing the trauma, removing the blood, less charring, and that's the bottom line of adhesion preventions. So no matter what we do to prevent adhesions, the genetic is going to take over. That's how I firmly believe.
I would like to say one thing though, because don't believe what I've said or what a study says. Maybe get an IRB, maybe get, just do a small case series that you're going to publish on just 10 cases. Just 10 cases. Go in and do a second look in 5 days. Don't do 7, because I used to do 7. Do it. Tell your patient that you're looking at this, and insurance companies pay for it too, by the way, or I wouldn't be doing it. So it's not an issue like, oh, I'm not going to get paid for this. And you say second look surgery. And
Lots
you
of
will be shocked at what you find. That's all I have to say is you will be shocked.
I've been done it 10 cases. I've seen it. They're always going to be just like exactly what you said. Adhesion was there. And within the 3 weeks, it's always there. You can break them down. So within the first week, as you say, that we're going to go in, you can actually free all these filming adhesion from the surgery.
I mean, I don't necessarily agree with that everyone's going to get adhesions or even 80%. I mean, maybe I haven't done second look, but I've re-operated on patients that I've operated on, and the majority of them have very little to no adhesions. So,
well, I wanna move forward into a different section. So let's talk about adhesion prevention, because we're gonna do it. So we'll start with you, Dr. O'Radi. You're working with different techniques in terms of adhesion prevention, and then we'll send it to Saruna and talk about what he is doing for adhesion prevention. Dr. O'Radi.
yeah, so there's many different things you can do for adhesion prevention. And as we know, and what we've been talking about, adhesions is caused by trauma, right? The tissue healing process is what causes adhesions. So in order to prevent adhesions, you have to think about every aspect of the surgery you're doing and absolutely minimize any kind of trauma in any way. And that means trauma touching injury, to trauma dehydrating in the tissue, trauma causing bleeding, trauma with the energy that you use causing burning with the energy, trauma with how much you're removing, what you're doing. And then obviously in doing things that prevent adhesions or help with the healing process. So it's just some of the things that we can address with adhesion prevention. Now, first of all, you have to minimize the amount of the invasiveness of the surgery you're doing. So using, as Dr. DeLemba said, using a robot, using the robotic instruments, you're causing less trauma because you have much more precision and you only have to touch and pick up what you have to touch and pick up. You don't have to, you have the wrist to be able to work around things rather than having to move things out of your way in order to work that way. Using mini microlaparoscopy, smaller incisions when you're doing less stage disease and you're not doing as much dissection. Minimizing the dissection as I will, going into correct planes, not causing bleeding while you're dissecting, minimizing the energy that touches the tissue. So I use a laser, for example, the CO2 laser, because that minimizes the amount of thermal damage that you can cause to nearby structures, and it gives you the most precise cut without any kind of tissue trauma. And you're literally not even touching the tissue. You're just using the laser to literally circumscribe and cut out the endometriosis without really damaging anything underneath or around that tissue. You're using it with very point precision, so that when at the end of your surgery, you've really minimized any tissue that's been touched, any tissue that's been squeezed, any tissue that has caused bleeding, any tissue that you've applied thermal energy to, and then being very precise and specific about what you're going to cut out, what you're not going to cut out, removing just the endometriosis, not like going into normal tissue. You don't want to go so deep that you're in normal tissue. You want to just go around the endometriosis, remove the endometriosis, shave it off, and then sew up and repair anything that you do. If you're going to remove an endometrioma off of the ovary, being very precise with the robot to remove the endometrioma and then repair that ovary exactly edge to edge so that the two edges heal together properly. And then other techniques that I use is I use adhesion prevention barrier, which is 4% isodextrin, which is called ADAPT, which is a liquid adhesion barrier that we put inside the abdomen at the end of the case. And it basically coats everything with this isodextrin matrix, and it hangs around. That fluid kind of sloshes around for 3 to 4 days. And that's during that 3 to 4 day process, having that solution there prevents those adhesions that Dr. DeLemba was again talking about. Most adhesions are going to form in those first 3 to 4 days after surgery. So putting this barrier in there prevents those adhesions from forming. And then the last method that I prevent adhesions is by suspending the ovaries away from the area of dissection, prevents that ovary from laying on the area that's been denuded or where you've removed endometriosis, so that it doesn't stick to that area. And we've all seen ovaries kind of stuck to the sidewall, stuck on the ureter, stuck in the cul-de-sac, stuck in the ovarian fossas. And by just elevating those ovaries away for, again, those 3 to 4 days where everything is going to reperitonealize and heal, and then releasing those ovaries that prevents the adhesions that can form around the ovaries and fallopian tubes. So those are just a few things. And my experience has been that when I have had to go back in for any reason to go remove an appendix or whatever, the adhesions that I've seen in my patients have been very minimal. And I think it's a combination. I have a whole lecture we're going to talk about at Endometriosis Summit about this, but I think being very, very cognizant of adhesion prevention is going to minimize adhesions. Now, have I prevented 100% of adhesions? No, of course not. There are still some, but if you minimize them, we can minimize the damage and the trauma that can happen from the adhesions.
Saruna, I have a question. Are you straight
Sure.
stick or you robotics?
I'm both, but if
Oh,
I kind of like, so I'm gonna go through this. I kind of opened adhesions, a lot of them with laparoscope, and then I do CO2 laser with the robot because I can see better if there's anything left behind. The reason I like to go open a lot of adhesions with the laparoscope because I like the haptile feedback. I like to feel things. I like to feel the tissue before I go excise it. And I also sometimes using a laparoscope CO2 laser with the laparoscope. I learned to do a CO2 laser with Kenny Sinervo, and I love it. I mean, I've been using it since then.
We don't love
And-
the laser anymore since they're no longer sponsoring the summit. Enough with the laser.
Oh,
They used to
okay.
give
We
us
need to
so
get
much
them to
money. Enough,
sponsor.
we're done with the done
But-
with Boston Scientific. No,
We need to
but
get
I
them
had-
to sponsor it. We need to get them to
Yes.
sponsor
it is an amazing tool.
Yeah.
It has a precision nothing else has. It'll be
Right.
interesting at the summit because Patrick and Mona are going to do a dueling podium on adhesions, and he is straight stick only. So it'll be interesting to hear you guys discuss this. What else is your approach, Saruna, to adhesion?
So I kind of like have an outline about adhesions. I have preoperatively I screen my patients by doing a history. I know if I'm dealing with a stage 4 endometriosis, if I'm dealing with the obliterative cul-de-sac in my examination, and then during the surgery, most of my patients, actually I decided to do majority of my endometriosis patient. I'll put the stent for both ureters because I know I'm going to deal with adhesions. So I either use the iris that I can see it with the robot, or I do ICG injection that I can see it under Firefly with the robot that I can dissect the adhesions. Then I do agree with Mona. The knowledge of anatomy is everything, So I usually try to dissect from the midline to the lateral, and I usually start with them safe spaces because I do pararectal spaces and paraphysical spaces because those are the safe spaces and avascular. Then I can approach it to the side, and I use traction contratraction technique. That's why I like to feel things. I use EEA sizer, for example, in a rectum that I can feel the rectum. And then I do meticulous dissection. And I disagree with a lot of things that if removing the adhesion is going to come back. I think the first lesson and the first thing I learned, and that always helped me, restoring anatomy is everything. Because when you restore the anatomy, it would help you in two ways. Number one, then you know what you're doing, and you can excise any endometriosis lesion and adhesion. And number two, if you get to the complication, you can fix the complication. You know where the ureter is, you know where the iliacs are, you know where your rectum is, you know where the sigmoid colon is, and you know where your appendix is. So I do think the restoring anatomy is everything. And I do think that for the past couple of years I've been doing on my own, and previously when I was a fellow, I think also when I was in endometriosis in the CEC, a couple of times we went back. We had to operate on somebody that I operated before for other reasons. They come back, and we had pretty good results of restoring anatomy, excising endometriosis lesions, and then we also use PRP. And now recently I use T-cell or Vistacell to actually surface the area after the surgery to actually speed up the healing process for preventing future adhesion. And I do agree with John and also Mona. I do think the first 3 to 5 days are very critical because that's where adhesions happen. So that's how I approach it. And I usually do a combination of a laparoscopy and a robot, both together. When I do think that I'm done with the haptile feedback, I do think that you have kind of like a vision feedback with robot when you pulling on the tissue and excising that. But the camera of the robot, the way actually you're looking at the posterior walls, I think is amazing.
I mean, I actually
Go
think,
ahead.
I mean, my opinion is that you can feel with the robot, and I actually, in terms of tension, counter tension, I actually use CO2 more for my dissection rather than actually stretching tissue or causing, because I feel like that can cause trauma. So I'll make the incision with the laser. I'll let the CO2, which is the insufflation, go in, and then I just tease the planes apart. I don't really put tension, counter tension.
I do this
Tease it.
actually. I do the same.
Gently.
I do the same thing. However, of course these are the minimal invasive techniques, and I do the same thing. However, I like to skeletonize. Like I like to feel behind the dense adhesion and skeletonize it and go slowly by slowly and open it. Either way, I think I agree. I think you can get some sort of feedback with the robot as well. You know, I mean, the more you do it, I think then you get a visual feedback, and we all get it.
Yeah,
You
there's
know,
a visual feedback.
but yeah, but I still like to feel the things, and I like to use my hands to open things. So I'm kind of like a little bit of old school minimally invasive surgery. But
So,
yeah.
Rena,
And I want to ask you,
when I grew up in medicine, laparoscopy was in its infancy, and
Yeah.
they said you don't have a tactile sense with laparoscopy. So, no, okay.
That's funny.
Can you
Yes,
talk
but
a little bit about patients don't know what PRP is? Do you want to explain a little bit about that?
Yeah, sure. It's a plasma-rich plasma. So you basically get the patient's serum, and they participate in a specific device. They get their own their own serum, helping them to heal. It has a growth factor. It has a platelet-rich serum that helping the surface the area, healing the area faster. So there's many things that you can use. People using stem cell, using the amniotic fluid, but those are more expensive. There's T-cell, there's Vistacell. There are different things that you can actually put it on the dissected area to helping with the prevention of adhesion in the future. But I do think the main take-home message is restoring anatomy, because when you're restoring anatomy, you actually, if you go back next time, you actually know where you're going. I think that's the first lesson for me.
So, it's actually go ahead, Dr. DeLumba, you go. You're waving. Good night, Dr. DeLumba. He's on dog walking duty. So I think some people have stopped. So with the endometriosis crowd, you often have people that have, I hate the word comorbidities, but other conditions. And so people with the autoimmune conditions don't often do well with the PRP because it's their own, it's already their own blood. You're using something else, Dr. Arati. What are you using?
So I'm using Adept, which is a 4% isodextrin. It's basically I hate to say it, but it's kind of like a sugar syrup. It's a very like slippery substance that kind of coats everything inside. So, and it's also an anti-inflammatory. So it coats everything with this slippery substance that's also anti-inflammatory. So it prevents things from sticking together, number one. And number two, it's kind of like soothing or healing, or, you know, so it helps with reducing the inflammation and adhesions. I do Dr. Fathatcher, you talked about Tisseel. So Tisseel, if you look at it, it's a fibrin matrix. So it's actually it's good for hemostasis, but I wouldn't use it as an adhesion prevention agent. I do sometimes use it if I feel like there's too much like ooziness or bruising, where there's just a lot of raw surface. But sometimes I'll use it in combination with Adept. But with fibrin, you have to be a little bit careful, because fibrin in itself can cause inflammation. So it's
You know, Mona, I think you brought up a good point. The thing is, we really don't know what causing iatrogenic adhesions. Like a lot of people talking about it bleeding, you know, maybe maybe by bleeding you can cause adhesion. Maybe post-op inflammation can cause adhesions. Those
Well,
are
we know
all the factors.
inflammation causes adhesions, right? Because anything that
Right.
causes inflammation causes adhesions.
But
And
if,
I think
but
that
if,
bleeding causes inflammation, which causes adhesions, just like infection, right? Anybody that develops a post-op pelvic abscess or an infection in the pelvis or PID is going to develop adhesions. Let me tell you what I've done. There's no randomized double-blind clinical trial about which one is better than the other one. However, I do think when after my endo surgeries, I wash the areas, like irrigate the area copiously, and then put T-seal, Vista-seal, or anything like that. If I do have a PRP is my to-go, but I sometimes don't have a PRP. And then, you know, I kind of like come down with the CO2 pressure to see if there's any bleeding or anything like that, and then finish the surgery. But anything can help. I mean, I do think this is another thing, and I agree with you. This is kind of like anticoagulation.
Dr. Chung, you have a comment?
Well, yes, adhesions have been on the face of the earth for years. Adhesion form from inflammatory changes. It doesn't matter whether that is iatrogenic or infection or anything you do to the pelvis. And they are all the same when they form. You can't tell. Endometriosis, whatever. Adhesion formation, number one. There were a study in 1990 talk about adhesion reformations. So whenever you lyse adhesions at the same site, you can bet that it's going to reform at about 60–80%. And you can quote Dr. Diamond's study back in the 90s. And adhesion prevention, the best thing is to not to use anything that we think that we can prevent adhesions. It's all the surgical technique, but again, goes back to the genetics. So the adhesion form, any inflammatory changes, infection, you form adhesions. That's when the fibrinolysis supposed to take away the adhesion. When that fail, adhesion form. So it's the person's underlying genetic, how well is the fibrinolysis to take away the adhesions. So this is a summary of what I have heard. Does adhesion cause pain? Yes and no.
But Dr. Chung, if you look at the studies with ADEPT, the adhesion for second look studies, adhesion reformation was less than 9 to 10% with ADEPT. So it does reduce the adhesion.
ADEPT, it's the same thing. ADEPT, separate film.
Yeah, they have similar, yeah.
All those are not going to work. And ADEPT information data was not that strong. So if I'm going to use ADEPT, I might as well just use the old-fashioned, put the lactate ringer and a couple of liters in the belly, just flush it around. ADEPT is going to dissolve. So what you were saying, I thought that was a good thing about adhesion prevention. It wasn't. So there was not any single thing on the face of the earth right at this minute can prevent a good adhesion. The study is just not there. Okay.
I agree. I agree with Dr. Chung. And there's nothing. I agree.
All these companies like ADEPT, Interseed, or if anything about Interseed, even though the strongest data on Interseed is for fertility to become IVF to get pregnant, it's not really talk about adhesion. So if we look at all the numbers, it's not there. The best is the skill and the technique, but can we really make it? Now, I would like to see somebody who have done surgery within a week to go back there and to see how much adhesion. Everybody gonna get adhesions, regardless. Feel me, a semi or fixed. The fixed adhesion doesn't cause pain. The filmy adhesions on the peritoneum and the ovary to the peritoneum cause more pain than the fixed adhesion. That's back in the 90s. The conscious sedation laparoscopy has already been done to prove that. So back in those days, they know that. So again, do we know a lot of adhesions? I wish there's something that we could do that to figure that out, but we don't. Adhesion on the same site, if you take them apart, you're going to see that 60 to 80% on the same site is going to form. And
Dr. Chang, I completely agree with you. I do think there is nothing better than no product is better than the other product. There's nothing there. It's just a better technique. We're just trying. I agree with you. I do think as a minimally invasive surgeons, I think one of the things we should do is it's all technique. We do our best to prevent adhesion as the best, and I completely agree with you. I think I completely agree about the genetic factor, trauma, and obviously lifestyle, and I completely agree that there's nothing that is better than the other one. There's no product. We can't say this is better than the other one.
We can't say there's no product though. We
Right.
can't. There are products out there. They may have similar outcomes, and that using them may help. We can't say that it's not helping or that it's the same as saline, because Dr. Chang, the study did do a randomized controlled study with saline as the control, and saline did have worse adhesions than number one.
All right. We gotta move forward.
Well, 2023, we talk about this in the 2010.
Yeah, but I think I have to say, products have come a long way, as have surgical education. You know, the surgery they did in the 90s is not the surgery they do today.
Right, right. I completely agree with you. I do think the surgery we do here right now is way better than 90s, because I do think that we are actually more trained. We already know a lot of better techniques now. Plus, we use the better product. I do think here it is. I do think that I can go in the middle. I do think I agree with both of you. I agree with Mona, and I do agree with Dr. Chang. I do think there's nothing better than the other one, but we can use our own hypothesis, our own judgment, and thinking, maybe if I put this to prevent more bleeding or prevent more adhesions, or maybe using a growth factor to helping reperitonealize the area faster, maybe it's going to help. Because I do think it's going to be very, very difficult study to have. I mean, I agree. Maybe it's 10 cases should be okay to go back within the 7 days to see how did you do that and how would you do that. I don't think it's possible in the private practice. I do think maybe that goes to maybe academic center that they maybe can sign up somebody for that.
Many numbers, and we know that carbon dioxide itself is a adhesion formation issues, and the dry carbon dioxide that infused to the abdomen can cause adhesion formation. So there are so many other factors in that. Like if you look,
there are other factors. I'm just saying that we should do everything in our power to try to reduce adhesion.
Well, especially we would want to do when it forms, it's gonna form. So unless there's a study with so many, the N probably need to be close to 1,000 to be able to have all the confiner, everything else to be able to sort that out.
All right, but we're gonna have to shelve this discussion till the endometriosis summit. At the endometriosis summit, we have a session on adhesion management with Dr. Orati and Dr. Young, who both are using two very different techniques. One is straight stick, one is robotics, and one is using Gore-Tex, and one is using a different material.
Oh, I know that part. So that's a good discussion with
right.
I know Patrick does use Gore-Tex. I know Patrick does use Gore-Tex. I know that.
While we're here, I want to, because we do a lot of patient education. And all three of you are going to have a different approach, as do I. Patient has the surgery, a clean surgery, and they come back with more pain, and they are hell-bent on more surgery because it must be adhesion. You're each going to get a chance to answer. What is your process for evaluating that? Because I, as a pelvic PT, am not somebody who assumes it's the adhesion causing the pain. Dr. Orati, what is your approach to that?
Well, I mean, the very, very first approach is a very good history and physical examination, right? Listening to when the pain started, how it started, what the type of pain, where it comes, when it comes, what relieves it, what positions, all of that. Like I can't assume that pain is pain. There's many different types of pain. There's many different onsets of pain. I will evaluate their bladder function, their bowel function, their pelvic floor, their sexual function, their, if they're menstruating, what their periods are like, where the pain is, when it comes, when it goes, to really get honed down on what is the pain. Does it sound like pain from inflammation from endometriosis? Does it sound like pelvic floor muscle tension or muscular type pain? Does it sound like a neurogenic pain, like a nerve hyperesthesia? Does it sound like a bladder source, like painful bladder syndrome, which Dr. Chung is always talking about? Does it sound like something that might be related to bowel inflammation? I have a lot of patients that have like SIBO and other bowel issues that have bowel pain. So it's a very difficult thing to like give you the general approach, but depending on their history and physical exam, then I would try to determine or hold down what the causes of their pain are and see, do they need nerve blocks? Do they need bladder installations? Do they need pelvic floor PT? Do they need gabapentin? Do they need, other treatments to try to figure out if we can get rid of that pain? I don't necessarily jump back into surgery unless I really do think it is recurrent endometriosis, or if I see some evidence of endometriosis either on my pelvic exam, ultrasound, MRI, or whatever, in that evaluation process. And I also do like tumor markers to see if CA-125 or 119.9 are elevated, indicating inflammation of the peritoneum. And then I'll treat accordingly. But having surgery after surgery after surgery isn't necessarily the best thing. Having said that, I do have a patient that every couple of years she'll come to me and she's like, Dr. Arati, my endometriosis is back. I know it. I can feel it. And I kid you not, like I literally have done 4 complete clean outs of endometriosis, like stripping all the peritoneum, removing all the endometriosis on her. By the way, no adhesions every time when I go in. So let me just tell you, and the endometriosis is back. Like you can see the lesions, they're active and they're back exactly where she thinks they are. So it is interesting that some patients are in tune with their body, and sometimes you do have to reoperate on patients where endometriosis has come back, even though you've done a complete excision before and you literally have the pictures and the videos to prove it. But some people, it just comes back and you have to reoperate. But it's not the first thing I will do. I have to try other things first and try to evaluate the other possible sources of pain and treat those as well, because you're treating the whole person. You can't just assume that pain is endometriosis. The endometriosis causes so many other side causes of pain, whether that be, pelvic floor muscle tension, whether it be nerve hyperesthesia, whether it be painful bladder syndrome, GI issues, et cetera, that you have to treat first and make sure that you're minimizing those kind of things, and then try to treat the patient as a whole.
Excellent. Dr. Fathatcher, anything to add?
Well, yes. Thank you very much, Mara. I do think very systematic. As somebody who is minimally invasive surgeon and also urogynecologist and pelvic floor surgeon, I kind of like categorize it to 3 levels. First of all, I do think, even though we're talking about endometriosis is 10% of women population, even though they said reproductive age, I have seen so many postmenopausal with endometriosis. I do think it's more common than that, 10%. So anybody with the pelvic pain coming in, I do think it should be endometriosis to me until proved otherwise if I see them. So number 1, I do think history and physical is very important, but I categorize it to 3 categories. Reproductive organs causing pain, or maybe GI, reproductive, and a bladder. I agree with you. Then I go to that. I look at the pelvic as a 3-level story. So the first level is a GU tract, which means bladder, kidney, and ureter. And then the second level is the reproductive system, including a uterus, vulva, vagina, any problem with any of those areas, cervix, and ovaries. Any problem with any of those areas, including fibroid, including cyst, including vulvodynia, including STDs, any of those can cause pelvic floor, can cause pelvic pain. And then also nerve problem, which is then a pudendal neuralgia. You have to think about a sciatica. You have to think about any other things. When it comes to the organs, when it comes to the muscle area, I always evaluate different muscle. Obviously, you're a pelvic floor PT, so we're always looking at different muscles to see which one, levator ani muscle, is it the which one, bulbocavernosus is painful. Specific muscle pain tenderness is very important. I do think it's important to check for obturators, internists, area that you can feel for the pinpointing the pain in the muscle area is very important. So I kind of like categorize it depends on where I kind of like how the patient is giving me the history of pain. Is it the pain because with the ovulation? Is it the pain related to menstrual cycle? Is it the pain related to intercourse? Is it the pain related to the bladder if the bladder gets full? So those are the area that I kind of evaluate. And as you mentioned, I kind of like target that area. But I always at the end saying, if I'm going for example, for Botox injection to pelvic floor, I always say you're going to be under anesthesia. Why don't like put the camera inside and take a look to see if there's any endometriosis? And most of my patients, they agree, and they like to be evaluated, and they want to know if this is not endometriosis causing this problem. So that's how I evaluate the patients. But before I come up to the conclusion, I do my homework. I do cystoscopy, I get the MRI, I do ultrasound, I do examination. I disagree with this area of the ACOG practice bulletin that they said the endometriosis symptom does not, and staging does not go with your examination. I do think if you examine patient correctly,
Yes.
you can actually pinpoint what you're actually feeling and the patient's feedback about the sharp pain. They can tell you exactly if this is endometriosis or not. And I think most of this pelvic floor muscle spasm that causing to the vulvodynia and vestibulodynia caused by some sort of irritation of the peritoneum inside that actually injured insulting a muscle going through the spasm. So I do think beside pinpointing it, there's some sort of a trauma.
As somebody who treats vulvodynia like for a living, yes, there can be something stimulating the muscles, but the reality is it's very well proven that it's the feedback through the spinal cord to the brain that's and then back down that's causing the spasm. And the spasm begins as a protective measure. It does,
right.
It's trying to protect the body. It's not necessarily a bad thing, but then it becomes chronic.
Yeah, most of vulvodynia is another thing. Vulvodynia is the extreme version of defense mechanism, right? So you don't want to go, anything goes inside, then you have a spasm, severe spasm. But I'm talking about people that they also have anal spasm, that goes the whole area. But if they have vulvodynia, which I had the extreme case not too long ago, she came to me because of vulvodynia. She was 34 years old, never had an intercourse. And she was crying. She says, "Oh, my fiance is gonna leave me because we can't even have an intercourse, and then I have severe dysmenorrhea that I can't even put the tampons in." So I put her on sleep. I scoped her. She had stage 2 endometriosis not too long. I injected the Botox to her pelvic floor, and she's using dilators now. But she also had endometriosis. So it started from like early childhood with the pain that goes extreme. That you have severe pain that you really, I think it blocks you psychologically somewhere too. I think it's trauma. If the trauma goes to your, it's so effective that goes to that defense mechanism that you really hold yourself up. And then the extreme is going to be the severe vulvodynia. But if you purely have vulvodynia, I agree.
We're going to have, who's really an expert on vulvar disorders. We're going to have Amy Stein on in just a few weeks. I'll also send viewers back to, there's a webinar with Abhishek Mangishkar and Dr. Gabby Mawad, where they talk about endometriosis in the vicinity of the hypogastric nerve and plexus, also stimulating vulvar issues. Dr. Chung, before we close out, anything to add to the reevaluation discussion?
That's a very broad subject.
I know.
ME is from reproductive to postmenopausal. And so they are different. Is endometriosis that have something to do with it? Maybe when they were younger, endometriosis is part of it, but when they're postmenopause, then they still have the symptom. Vulvodynia, vestibulitis, that you have to rule out primary is pudendal neuralgia until proven otherwise. So you gotta make sure that it's not the pudendal nerve problem before you can think that it's primary vulvodynia and vestibulitis. And as you know, pelvic organs, it's like a Christmas tree. My gosh, the pelvis, the female reproductive organs only created pain for about 20%. The GI is about 30. Myofascial, the pain in the muscle is about 20. And then you have the genital urinary is about 30. So basically they all share, but they don't always become a single entity that causes the pain. That usually is multifactorial. It's like the connection, they all involved in it. If the GI is involved, if the blood is involved, the muscle is involved, do they have endometriosis? I'm not quite sure. Maybe endometriosis is the fire fanner. They just fan the fire. So as of yet, we can talk about all of these, but how are you going to approach it? Where do you start? And bladder is part of the biggest, it's the biggest organs in the pelvis. It's more than a liter sometimes that involved in the bulk of it. But the nerves involved in the bulk of it, the inferior hypogastric nerves also involved in it. So for pain is different. Endometriosis is different. If endometriosis causes it, you excise it, the pain's supposed to be gone. But then if the pain comes back, I think all of those are here are expert surgeons that either you miss a spot or two that you may have seen it on the recurrence, but how fast are they going to grow? Within a year or 2 years, 3 years, they're going to grow so much that causing the same pain. So I believe that in myself, when you have an expert surgeon remove the endometriosis, when the pain comes back, it doesn't mean that it's endometriosis. It could be a pelvic neuralgia. It's just the nerve, the muscle, whatever that is causing the problem. So especially like Mona, your expert surgeon, you remove it, it's gone. I mean, are we missing one spot or two? Maybe when it's come back, it's just one spot or two. How fast endometriosis grow? Is it going to be a big nodule or just a couple of implants? So we got to think about that. When the pain comes back, it doesn't mean that it is endometriosis comes back. It could be, I don't know, it's a neuralgia. It's just the nerve is starting to come back and causing the problem. So that's my take. So, hey, Sally, I just have the paper finally submitted.
Oh, wonderful. All right. We are 10 minutes over. I'm very excited about that, though. I've been waiting a lot of years. Okay. So if this insanity appeals to you, we actually have a lot of doctors commenting all over Facebook and LinkedIn. If these conversations where people get to talk openly about different opinions about the same thing, which is really very common in medicine, appeals to you, please join us at the Endometriosis Summit, March 8th through the 10th, available virtually and in person in Celebration, Florida. I will see you all soon. Good night.
Good night. Good night.
Is that right?
Good night.
Good night. Good night. Good night.